I am Barbara Rosario for ISSNAF Stories, and I'm with Professor Alessandra Ferrajoli, Deputy Chair, Professor, and Medical Director at the Department of Leukemia at the University of Texas in Houston. Benvenuta, Alessandra.
Grazie. Thank you, Barbara.
Let's start with ISSNAF. So you were recently nominated member of its scientific council. Is there anything in particular that you hope to achieve in this role?
I think ISSNAF is an excellent organization and is doing a lot for young scientists. And for somebody like me that has spent all her career in an academic environment, and therefore teaching is a high priority and really helping the development of the future leaders in the field of hematology and oncology is what I do. It's a perfect match because I know that ISSNAF, through its activities, has really helped some of the now mid-career scientists that I know be propelled into success in the academic field. It's a very prestigious award and helps a lot when you are in the early phase of your career.
You are mentioning the Young Investigator Paola Campese Award, I believe. Is that right?
That's correct. That's the one that I've participated with the ISSNAF so far.
Tell us about your job and research.
So I have spent my entire career at the University of Texas MD Anderson Cancer Center. This is a very large teaching hospital that belongs to the University of Texas and has really the mission of improving the life of patients with cancer. This happened because of an opportunity I was given during my Italian training. I was awarded a grant from IRC, the Italian Association for Cancer Research, that allowed me to spend 2 years at MD Anderson doing laboratory research in the Department of Leukemia. And that was while I was doing my internal medicine training in Italy at the University of Perugia. And I was also very, very interested in the way that clinical training is done in the United States. So when I completed my training in Italy, I was at a point of my life, kind of a decision point, and I was lucky enough to be given both opportunities to continue my clinical training in Italy or to move to the United States for additional clinical training. So I chose to move to the United States, in part because I wanted to experience this different way of training. And I thought it was going to be a temporary move, and I was going to be returning to Italy after completion of my training. But somehow I found myself, how can I say, very involved with the opportunities and very happy about the opportunities that I was given here. So I decided to stay a little bit longer, and now we are 25 years, no, more than that. Almost 30 years later, 29 years later, since I returned to Houston. It was in 1995 to continue my clinical training, and I've been here since then. My work focuses exclusively on patients with leukemia. I see patients with any type of leukemia. However, over the years, I've become more specialized, and I've done most of my work in a specific type of leukemia called chronic lymphocytic leukemia. And so I do see a lot of patients with chronic lymphocytic
And what's
leukemia.
that exactly? Can you?
Chronic lymphocytic leukemia is a type of leukemia that belongs to the non-Hodgkin lymphoma group. It's a chronic lymphoproliferative disorder. It's actually the most prevalent leukemia in the Western world. It's very common in Italy too, because it's typically a disease of people of Caucasian origin in more than 90% of the cases, and is a disease that tends to occur more commonly in the later part of life. It's a disease of older patients. So in Italy, being a fairly homogeneous country, Caucasian background, and also a country with a lot of old living people, it's quite common. So what I do, I specialize in the diagnosis, supportive care, and treatment of this type of leukemia. I do a variety of programs that go from evaluating prognostic factors to do what we call supportive care with vaccination, cancer screening for these patients that are at high risk for other types of cancer. And then I conduct clinical trials that evaluate the the most promising upcoming treatments for this disease. So this is what I do most of the time, and it's been very rewarding because I've seen a complete change in what the options are and also in what are the results of the treatment. However, because I work in a teaching institution, I also have other commitments that relate to teaching and formation of resident and fellow. I conduct the quality checks and quality improvement for our department. And I also have a role in the management of the outpatient center, and I assist the chair in the management of the academic department.
Cancer used to mean a death sentence. How close are we to the point we won't be longer die of cancer?
Well, it really depends on the type of cancer and on the circumstances. I often give an example. I have some of the patients, I am very lucky to follow this type of patients with chronic lymphocytic leukemia, that it's mostly indolent in nature. So I have some patients that I've been following in my clinic for over 20 years. And these patients really have a life expectancy that is similar to the one of somebody without cancer, as long as you do all the proper, health maintenance, and then you use the right treatments at the right time. Whereas that is not for any kind, all the kind of cancer. I have to say that we are really getting so close to discovering for each type of cancer what are the specific targets that we should direct our treatment toward. So I see that with the progress, and particularly with the pace of the program that we are making in the world of oncology, going from, again, targeted therapy for specific cancer, using the immune system for all what we call the cellular therapy, and just knowing more and more about the unique features of each type of cancer. I think in the future we will be able to cure a large proportion of patients with this disease. I think the outcome of patients with cancer is already as good as the one of patients that have other conditions, such as cardiac problem or respiratory problems. And I think it's gonna probably in the future be even better.
If I understood correctly, you mentioned immunotherapy. Can you tell us more about the difference between chemotherapy and immunotherapy, and can be used to treat all kinds of cancer, and including leukemia?
So it's really chemotherapy is a treatment, a generic term that involves many, many different types of chemotherapies. But this is based mostly on a chemical interaction with the cells and blocking the cell from replicating in a way that is fairly non-specific for that cell. In fact, when we talk about classical chemotherapy the patient receives, that's when the patient tends to have the hair loss, and that is due to the fact that as we stop the replication of the cancer cell, we also stop temporarily the replication of, for example, the cells in our hair, and that cause the baldness that is typical of the cancer patient. We now have different type of treatment. We have what we call targeted therapies, and targeted therapies really focus on specific advantages that the cancer cells have and that normal cells don't have. We call those switches. So they focus on particular switches that are on the cancer cells, with the idea that we can use medication. And many of those are oral medications, so something that you take by mouth that goes and turns off that particular switch. So the advantage of this treatment is not only they are more specific for your type of cancer, but also they have better tolerability for the rest of the body, because the normal cells may either not at all be affected by this treatment or only be minimally affected by this treatment. And another type of therapy that now we do is immunotherapy. So sometimes immunotherapy can be done with monoclonal antibodies. Those are the antibodies that our body makes in case of infection. They are built up in the laboratory for some specific, again, characteristic of that cancer cells. And so when you receive them, your treatment does not have the classical side effect of chemotherapy, but it's more working through the immune system, where those monoclonal antibodies, what we often say is like they put a flag on your cancer cell, and then the immune system helps the monoclonal antibody to destroy the cancer cell. And then you can have other type of immunotherapy, for example, that are called cellular therapy. And cellular therapy goes from the use of your own immune system, and this is what we call CAR-T, chimeric antigen receptor cells. And again, the cellular therapies have helped tremendous in the advances of the cancer treatment, mostly because one of the characteristics of cancer cells is that they become almost non-visible to your own immune system. So your own immune system has allowed the development of this cancer. That is a mistake that the immune system makes, because our immune system protects us from infection, but also protects us from cancer by destroying them at the beginning. If your immune system has allowed the development of a cancer in your body, that means that for whatever reason, those cells were able to trick your immune system and not to become very visible to it. By doing cellular therapy, we recreate an ability of the immune system, either your immune system or the immune system of a donor, to again see those cells as something that is not right to have and that should be destroyed.
And it is not just a level of research, they're actually being used currently on patients,
Oh,
correct?
yeah. Many of those are approved by the FDA, they are approved by the EMA, and they are used every day for the treatment of patients with cancer, both here and in Europe and in many countries in the world.
Tell us more about your journey from growing up and studying in Italy to Houston, Texas.
Yeah, I grew up in central Italy. I'm from Macerata, and in Marche. And I then I lived for 11 years in Perugia. From being from Macerata, Perugia was one of the closest medical schools available to us. And then from Perugia, I came directly to Houston through the opportunity of the HILC fellowship. I was initially pretty disappointed because growing up, one of my passions has been skiing. I used to ski regularly, many days a year. And I also love mountains and the outdoors. And I don't think there is a city that is more flat than Houston. I mean, there is zero mountains here. And when you want to go skiing, you need to get on the plane to go skiing. But my family always encouraged me to explore and not to be afraid and to go where I think the best opportunities were going to be.
What do you like the most about living in Texas?
There is not much that I like about living in Texas. So the weather is terrible. Everywhere you try to go is really, really far. But there are also some positive aspects. The positive aspects don't have anything to do, or maybe very little to do, with Texas. First of all, the hospital where I work, the MD Anderson Cancer Center, is a wonderful institution. And it's very exciting to be here. Houston is very rich culturally. So I have had a regular seats at the opera since I've been here. So the opera is excellent. The symphony is very good. There is a lot of foreign movies that are shown. So I like that. But I think the most is the humanscape. And when I say humanscape, I mean the wonderful friends I have in Houston and the wonderful relationships that I've been able to develop professionally. So life is good in Texas, even if I wouldn't advise anyone to come here for the landscape or the weather, not talking about the mosquitoes and other real pests.
You mentioned the mountains. Is there anything else you miss about Italy?
Oh, I miss, the everyday life, the pace of life, and the fact that you just go out in the street and you just go around the corner and you can buy bread, fresh bread, and everything is close. So I miss that, small town life.
Yeah, I always ask that question, and that's most people miss about Italy. That's true. Also for me,
Yeah.
for sure.
Yeah.
What piece of advice would you offer a young Italian researcher in your field coming to North America?
Well, first of all, they need to be very proud of their background, and they should be very proud also of the level of education that they receive in Italy. Because I do feel that Italian schools, Italian universities are at a very high level, and they really, at least in my case, they prepare me very well for my career. So they need to know that they are coming here from a place, from a country that is at high level of everything: technology, medical practice, discoveries. And so they should not feel like they are second-class citizens. They should feel very proud of their origin, and then they can use their brightness and their energy and their devotion to academic career to once they come in the United States. So I would say take the opportunities that they are offered to you. Remember that you are ready, and remember that you can do it.
But was there any particular challenge that you had to face that was particularly difficult for you?
There are always challenges, and there are challenges, that are different at different phase of your profession. For me, I would say at the beginning, the challenge was maybe with the pace of work and the fact that when you come here for research in particular, and also for clinical training, you don't have time for anything else. That really absorbs all your life. And I think that's a little bit different. I think in Italy, we are better in work-life balance. So I would say my first challenge for the first years of my career was trying to get some work-life balance.
What can you tell about your experience as a woman in science, both in the States and in Italy?
So in the States, I would say from the beginning, they treated me exactly as a man. There was no difference. There was no difference in terms of, shift. There was no difference in terms of offering me opportunities to do things. I really didn't perceive any gender discrimination when I arrived here. Then later on, as I advanced more in my career, then yes, when you're trying to get to higher positions and establish you academically, it is more challenging to be a woman. So what I have found challenges has been, again, to be a mother and to be at the same time productive in my field, and that has required some balancing priorities, decisions. And then later on, when you really need to take leadership positions, then I do feel it's still more challenging for a woman. Things are changing. There are a lot of initiatives that now are focusing on making sure that whenever there is a selection for a leadership position, at least a certain number of women apply to give a fair opportunity, but still it is still a little bit challenging when you are a woman. And in my career, I have had occasions where I was the only woman in the room, and that can be felt a little bit, and there are I have to say, some of my male colleagues and people in the field of work have very assertive, very strong personalities, and I don't. I tend to be what I think women we tend to do, that is having more some self-doubt and even think, oh, I'm not sure I'm good enough for this. This is something that as a woman we tend to do. We are more critical of ourselves. And I think we are more prone to question our value, even when maybe it shouldn't be questioned. So yeah, the advice I give to women in academia and in the medical field is to make sure they remind themselves that they have done all the training and they have all the qualification of their male colleagues.
Well, grazie mille, Paola, for your ISSNAF story.